morning. How many people here have seen a traumatic arrest in the emergency department? Some people. How many have seen a cardiac arrest in a kid in the hospital and in any other setting? So, these are very, very upsetting situations. A kid comes in, you're in the trauma bay, the kid arrives, full arrest, CPR is being done, and the team is understandably upset because it's a kid. A lot of things have to be done quickly, and what happens is a lot of times that there's a lot of chaos and a lot of people in the room trying to help, trying desperately to do something. And what I want to do today is give you some recipe about how to think about the traumatic arrest so that your role is a useful role and that you're actually doing something to help the child. Or if you have no role in taking care of the patient, that you can step away and let the people who are taking care of the patient support that role if you don't happen to have a role. So in our trauma app, we have this algorithm. I'm failing on the advancing here. Joanna, how do I move forward? Click, click, click. So in our trauma app, we have, how many have seen our trauma app or have access to our trauma app? Do it like that. Okay. So our trauma app is something that we put together that has all our algorithms in it, as well as recommendations for how to translate labs into testing, what strategies they use for imaging. And one of the things we have in there is this traumatic arrest algorithm. And this is something that was come up with by the Western Trauma Association, and this applies for kids who are less than 15 years of age. And I just want to go through a few key aspects of this to sort of understand. So you're standing there in the trauma bay in the emergency department, and a kid comes in with CPR. How do you think about that patient, and what's the best way to proceed? So one of the first things you want to do is determine if the kid has signs of life. Because if the kid doesn't have signs of life, then the options for what you can do to help that child are much less. And I'll talk about what the signs of life are in a moment. The second question you want to ask is the patient have some kind of injury that's simply non-survivable? So, for example, if the patient has, some head injury that's devastating, brain matter's coming out, the head is obviously crushed or something devastating like that, then that will factor into your decision making. Understanding how long the patient had CPR before the patient arrived in the hospital, I'll talk about that, how that's an important thing. And that pre-hospital providers, when they're doing CPR, that's a high stress situation for them. They're not often used to taking care of kids. They often don't do CPR in a pre-hospital setting, and so it's very difficult for them to sort of put their mind together about how long CPR was been done. But it's important to see. And so the key thing is this box right here. Is that the patients where treatment is not futile, you should do some very simple, basic things before stopping. And these simple basic things are putting in an airway, so intubating the patient, starting IV access and resuscitating the patient, and doing needle or finger thoracotomies. And we actually don't want people using needles. We'd rather you do, the teams in the trauma bay do finger thoracotomy. And what's that? That's basically where you make an incision over the chest and you put your finger in. You don't put a chest tube in, you don't need a pleurovap, you don't need anything fancy, you don't need an x-ray, you don't even listen to the chest, you just put your finger in. And the concept is, if the patient has a tension pneumothorax, this maneuver will take care of it immediately. And the reason that you use your finger instead of a tube is because, and the reason you use your finger ideally instead of a needle, is you just want to get into the chest quickly and not fool around with equipment and things like that. These maneuvers here, airway, oxygenate, And so airway, oxygenate, resuscitate, which is fluids, single thoracotomy. This should take literally minutes. This is not a 20-minute affair. This is not a 30-minute affair. This should take you less than 5 minutes to do. It should take the team less than 5 minutes to do. And so just to follow along this algorithm, signs of life, which I'll talk about in a moment, does the patient have a head injury which makes the patient non-survivable? If the patient has a head injury that makes the patient non-survivable, you should simply stop. So doing these maneuvers, intubating and all these other things, this is a waste of time. You're not helping the patient in any way. If you do these maneuvers I just said, and again, it should just take minutes to do, you ask again, did you make the patient better? Does the patient have signs of life? If the answer is no, there's nothing you can do for that patient. You need to simply stop. And so by the time that he just presented to you, that's like minutes. So the patient has no signs of life. You do these maneuvers, they still have no signs of life. That patient is non-survivable. Should we keep doing CPR? Should we wait for the parents? Should we do other interventions? Well, we'll talk about that in a moment. The simple answer is no. That patient has a non-survivable injury, and there's nothing you can do to help the patient. The pattern of injury is important in traumatic arrest because there's certain patterns of injury that make doing an intervention more likely to be successful. And the key thing is whether it's a penetrating or blunt injury. So if you have a penetrating injury, then there's something that could be cut or torn or disrupted that can be repaired. On the other hand, if you have a blunt injury, the likelihood that you have something discrete that can be fixed is much less. So that's why, and I'll show you some ways to think about blunt versus penetrating, that's why thinking about whether knowing the mechanism is important in the decision making about what to do. And we'll talk about ED thoracotomy and let's see. Okay, so I alluded to signs of life. Joanne, I'm failing here. Okay. Hang on. Okay, now I got it. Okay, signs of life. These are the signs of life. This is the critical thing to know when a patient comes in with a traumatic arrest when they show up. These are the things you should be focusing on and identifying immediately, because this determines, if you saw in the algorithm, this determines kind of where you're going in the whole decision tree about things. And this is, you have signs of life, pupillary response, your pupils react, you breathe or move, you have a pulse, you have a blood pressure, the corollary of having a pulse, your kid is moving, and then you have meaningful cardiac activity. And meaningful cardiac activity, this is, let me give you just a definition of what this is. This is like a sinus rhythm, identifiable rhythm. This is not some, erratic rhythm. This is some meaningful rhythm that the patient has. These are signs of life, and the patient has signs of life. That's a good thing, and it's possible for the patient to survive. If none of these things are present, we already saw in the algorithm that you're pretty quickly going to terminate if you can't get them back. So finger thoracotomy. Maybe you can do it, and I can say next slide. Yeah, this is not working. Maybe if you can. So if you saw in the algorithm is that the basic intubate, give fluids quickly, finger thoracotomy. Give me next slide. That's a maneuver that we're going to be doing pretty quickly and early. Next slide, please. So let me talk about ED thoracotomy. So if a patient has a penetrating injury that has something that can be fixed, that's the #1 circumstance where we're doing an ED thoracotomy. And this is where we're opening the chest to try to identify something that can be fixed and fixing it immediately in the trauma bay. So when should you do an ED thoracotomy? Next slide. So this is guidelines from another trauma organization, the East Trauma Organization, that talks about when you should think about doing an ED thoracotomy. So you do the maneuvers, you look at their signs of life, you do the basic resuscitation maneuvers, and now the patient has you're now trying to decide if there's something that you can do to fix that patient. And you can see that there's three buckets that patients get divided into based on the mechanism of injury. One is that they have a penetrating thoracic injury. So common sense says if you have something penetrating in the chest, there may be something in the chest you can fix by going into the chest. So it makes sense that if you have signs of life and a penetrating chest injury, getting into the chest is something that will help that patient. On the other hand, if the patient has no signs of life, that patient may not be survivable. If the patient has a penetrating injury outside the chest, then the value of going into the chest is less. It's common sense because you're going into the chest to fix something or to clamp the aorta. And so if there's nothing to fix, being in the chest doesn't help. And then if you have a blunt mechanism, the likelihood that something discrete that you can fix, it's much less. And so if there's go at the very bottom, if you have a blunt injury and there's no signs of life, that patient, doing ED thoracotomy is not going to help that patient whatsoever. You're not going to save the patient. Next slide. So there's general rules about how to think about blunt and penetrating injury. And interestingly, the algorithm that I showed you at the very beginning did not have time on there. But most trauma surgeons have this sort of mental view of what the time of CPR is that makes ED thoracotomy something that's an acceptable maneuver to do. And so the general rule of thumb that people, I think, mostly have converged on is if the patient has a blunt mechanism and they arrest in front of you, then you may be able to do something for that patient. If that patient showed up in the hospital with a blunt mechanism and had 5 minutes of CPR, 10 minutes of CPR, those patients statistically are not survivable. The penetrating injury, again, you have a little more leeway because it's more likely there's something discrete that you can fix. The time of CPR before the hospital when ED thoracotomy is something you consider in a penetrating injury. Some people say it's less than 15 minutes, some say it's less than 10, but you have a little bit more time, again, because there's something you can fix. Next slide, please. So how do you do with ED thoracotomy? Well, the concept is that you're going into the chest to fix stuff. So there may be a cardiac injury or pulmonary injury that can be stitched. You could clamp the aorta, and that increases now increases central blood pressure and cerebral perfusion. So that's a maneuver that you can do while you're looking for something to fix. The patient could have cardiac tamponade, so you basically open up the pericardium and let blood come out to release the pressure. You could do open cardiac massage, directly squeeze the heart, which is a much more effective way to do cardiac resuscitation. Or then you may see air that somehow, by some mechanism, air got into the vasculature that you could get out. Next slide, please. And so here's how you do it. So don't try this at home. It's something that you have to have seen a few times, but I think it's important, even if you're not doing, to understand how it's done, because when you're seeing it, understanding kind of what the dynamics are will help you help the team to do that. So the way it's done is the patient stays supine. The prep for this is no prep. We're trying to save the patient's life. The only sterility part of it is you have to protect yourself and the team from blood contamination. And so, sterile gloves, sterile gowns, given the time urgency of this, we'll worry about sterility later. We'll give antibiotics later. If the patient survives and gets an infection, we'll deal with that later. And what you do is you do a submammary incision on the right-hand side. So you stand on the left-hand side of the patient, got this wrong. Stand on the left side of the patient, make a submammary incision on the left-hand side and get into the chest. And this is not from the time you start the incision until you're into the chest should be less than a minute. It should be quick. So the team is just getting in. So so you make the incision. I mean, and this kind of looks like they're doing some like fancy layers and identifying. You just take a knife and you just cut straight into the chest until you get into the chest. You put a chest wall retractor in to spread the ribs, and now you have exposure of the lungs and the mediastinum and the heart. And you can start doing maneuvers to identify and manage injuries like I was explaining a moment ago. Okay, so I think so one of the things that happens when an ED thoracotomy is done is that, let me back up. When the patient comes in with CPR, we've discouraged the teams from having a CPR line. The concept of CPR line is that people doing CPR will get tired, and we want them to have effective chest compressions. And so what we do is we have a line of people that stand next to the patient's bedside, so that one person gets tired, the next person is immediately available. For trauma arrest, we do not want you to do that. We don't want that line there. The reason we don't want that line there is the most important thing to do in a patient who's having an ED thoracotomy with incident arrest is to get into the chest quickly. We also don't want defibrillator pads put on the patient. And so why not defibrillator pads? All other arrests, you put defibrillator pads on. Well, the problem is you put the defibrillator pad on the patient, now it's in the way of the team trying to get into this patient's chest, and the likelihood that the patient with a traumatic arrest, a kid with a traumatic arrest has a convertible rhythm is near zero. So having a CPR line gets in the way. Having defibrillator pads on the patient gets in the way. You stand in want them to be in the chest within 60 seconds of making the incision. No sterility, don't worry about sterile. The most important thing is protect the team. Okay, so we should watch this video. And this video will give you a sense of the chaos of what's going on and the speed that this needs to happen. And you can pull this up on YouTube also if you want to look at it again. We have a link we could probably This is a cartoon that you see very frequently, and they talk about ED thoracotomy, about the tricks and trades of it. We'll talk about it in a moment. We can probably copy the link.
In this video, we demonstrate an actual open thoracotomy. Viewer discretion is advised. The left anterolateral thoracotomy. Every second counts. These steps should occur almost simultaneously and should not significantly delay the procedure. Place several towels under the left scapula and raise the arm above the head. The patient should be intubated. Insert a nasogastric tube to differentiate the esophagus from the aorta. Make a left anterolateral submammary incision.
When you're cross-clamping the aorta, you're not cross-clamping the esophagus with it.
To expose the anterolateral fourth or fifth intercostal space.
One effort. Just down.
All the way down to his shoulder blade. The shoulder blade.
So you see these guys, they're just using regular blue gloves. There's no sterility.
The
And they're
initial
just
incision should be
getting
made
into the
rapidly
chest
and
as quick as they
sustainably at
can.
the 4th to 5th intercostal space. It must extend
If you
from the
just go
sternum
under
to
the
past the
nipple
posterior
line,
axillary
the
line.
submammary
Anything less will
line,
cause unwanted
that'll get
delays
you in
as
the
the
right place
operator will
into
have
the
to
chest.
extend the incision in order to access the heart and the aorta.
Go in between the ribs with the Mayo scissors.
Once you get into the chest, then you put, so they made the incision down through the fat, and now they're getting into the muscle, just taking a pair of scissors and just
Scissors are
cutting through
used
the
to rapidly
intercostal
cut the
space.
intercostal
So they
muscle.
get in.
The scissors should cut along the top of the
You know,
rib
there's
in
no
order to avoid
electrocautery
the
here.
intercostal artery.
There's no breathing control measures that are being done. They're simply getting into
The wrong way. Go ahead.
Yeah, for the handle.
They still want to open it up. He's bleeding on the right chest.
The next maneuver they're doing is they put a chest wall retractor in.
You got the big hand.
In this video, note the importance of elevating the patient's arm above his head to allow adequate space
And they put
for
you
placement
put
of
the
the
chest
rib
wall
spreader.
retractor in so you get the
Additionally, the rib
exposure.
spreaders are placed with
the
the ratchet
trick
bar
is
next
that
to the bed
you want
so
this
that the
part
wound can be easily extended if a clamshell chest opening is needed. The ribs are rapidly spread by turning the ratchet bar handle.
With a syringe.
Should be a light 30.
You're going to need,
And so they're still doing chest compressions. The chest compressions are probably getting in the way of the patient. So, are these chest compressions worthwhile for this patient?
Right now, I'm at the
Best thing to do is to get into the chest and fix the problem. So if those chest compressions are getting in the way or disturbing the team's work, just stop it and just get into the chest.
Once the heart is exposed, perform a pericardiotomy if indicated.
And
This
so,
procedure is
so what
performed
they're saying is,
anterior
once
and
you're into the
parallel to
chest,
the left
then you get
breast
into
nerve.
the pericardium to
Begin the
make sure
incision
there's no
near the
fluid in the
diaphragm
chest,
to
make sure
avoid
there's no
injury to the coronary artery.
hemopericardium.
Lift the pericardial
And-
sac with toothed forceps
And
and
the
use
technical
scissors
part
to make
is
a
you don't
small
want
hole.
to
Extend the incision with scissors or
bag
blood
the phrenic
dissect
nerve
with
on
your
the way
fingers
on the
in
way
a
in there.
cephalad
The
direction
phrenic nerve
along the
is
anterior
parallel, and so
aspect
you
of
make
the
the incision
pericardium.
parallel to get in the
Extend the
pericardium,
incision
not the
so
other
that
way.
it reaches
So
from the
the other way you'd
apex
be
of the
crossing
heart
it.
to the root of the aorta.
But the point is that you get into the pericardium, so you want to make
Deliver the
sure
heart.
there's blood in the blood in the pericardium and reducing the pressure over there.
Blood
fluid, whatever we
he's
got.
definitely got cardiac activity. That
And you
mammary
can see if there's
artery.
any lung injuries. If there's any lung injuries, you can manage those by clamping them off. You can grab the lung and
Are you sure you got
use
aorta?
it.
I feel a pulse. He's got a pulse right now.
You've got good cardiac activity.
For persistent hypotension after performing
And
the
then
thoracotomy
one of the
and
maneuvers
pericardiotomy,
to increase the patient's
institute
central blood
temporary
pressure is
occlusion
you
of the
clamp the
descending
thoracic aorta.
This
And that's the
maneuver
reason
can
you put a
maintain
nasogastric tube in
myocardial
before
and
you do this
cerebral
procedure.
perfusion.
So you can
Aortic
distinguish
occlusion has
the
a role
aorta,
in
which has
controlling
no
hemorrhage
blood in
below
it
the
and not
diaphragm.
pulsatile from the esophagus.
OG tube down so you can fill the.
Yeah, just make sure, put an OG down.
I can't grab my hands are.
That gives you an idea of
Identification of the aorta can be difficult during emergency department
the
thoracotomy.
goal is
If possible,
not more chest
first pass a
compression,
nasogastric
getting into the chest, and it's doing simple maneuvers to try to increase the central blood pressure and to fix a problem that caused the patient to arrest. Okay, next slide. And so here's some top 10 tips. I think this, let me highlight a few things. Be bold, don't hesitate. We've had teams that stood there for 20 minutes deciding whether or not they should do this. Once 20 minutes go by of CPR and you're thinking about it, then it does nothing. So you got to do it like within minutes of the patient arriving, or else it's going to do absolutely nothing. See some other little things in here. You know, and that. Let me go back one more. So things that you, if you're not doing this, I think there's some things that you need to know. Is you need to know what kind of decisions the team is making about when to stop, when futility is reached. And futility is reached when you have no signs. You did this ED thoracotomy. or just in general with an arrest, if you do all your maneuvers, you go down your algorithm and you have no signs of life, then you need to stop. There's nothing else that you can do. Knowing when to intervene, so knowing how long was the CPR time? Is it a blunt injury? Is it a penetrating injury? Does the patient have a devastating head injury, which makes this none of these resuscitation maneuvers worthwhile? The team should be doing actions that support the patient's resuscitation. Standing there, CPR lines, observing, being there available in case something is needed. Those aren't things that are helping to move forward this process. This has all these maneuvers, whether the patient gets an ED thoracotomy or not, have to be done quickly. And then the corollary is avoid actions that don't make a difference. That's why we say stop. Get rid of the CPR line. Get rid of the defibrillator pads. When somebody's trying to get into the chest, don't do chest compression so they can get into the chest faster rather than having a moving chest. So, do things that help support what's going on. Okay. Quiz. You can just to the quiz slides. Go back. Okay, here's the first slide. Which is the following is a criteria for no signs of life? Which of these things means no signs of life? PEA, GCS4, agonal respirations, reflexive extremity movements, non-reactive pupils. Which is it? Just call it out. E, right? No signs of life. All these other things are signs of life. All right. Okay, here's a scenario. A 2-year-old boy is hit by a car. Blunt mechanism. CPR was begun at the scene. He arrives. Chest compressions are still underway. The EMS team estimated his transport time was 20 minutes. On presentation, he is in asystole, has fixed dilated pupils, has no EKG rhythm, has no movement, and no pulses. The next best step is to intubate, stop the resuscitation, give epinephrine, perform an ED thoracotomy, or give a rapid 20 cc per kilogram fluid bolus. So I think let's go to the algorithm, next slide, and see. So personally, if it was 20 minutes of resuscitation and the patient had no signs of life, I would probably do B and stop the resuscitation. This is what the EAST guidelines say, and if we follow through the top, no signs of life, yes, no signs of life. The patient has no severe brain injury. Nothing about the story says there's a severe brain injury. We don't know that yet. Then we fall into this box right here of airway, oxygenate, medical resuscitation, needle or finger thoracostomy, ideally finger thoracostomy. And so we would spend 5 minutes to do these measures and then stop if there was no signs of life. So the answer to the previous question, personally, it was 20 minutes of resuscitation, and I could verify it was 20 minutes of CPR. Pre-hospital, I would probably stop because that patient is not going to survive. Our algorithm, not to confuse you, but the algorithm said you can spend 5 minutes to do these maneuvers to see if you can regain signs of life quickly. Okay, next slide. A child arrives in full arrest after an injury. Which of these should take precedence to increase the chance of survival? High quality, excellent chest compressions, immediate treatment of hypovolemia, cardiac tamponade, or tension pneumothorax, securing a stable airway, cardioversion, or administration of appropriate dosed epinephrine. So the answer that people often will go to is A, we're taught good quality chest compressions is essential for cardiac arrest. In this scenario, you need to refocus your attention to we need to fix something. And if we can't fix something, doing chest compressions doesn't do anything. Doing chest compressions when the heart is empty, has no blood in it, does absolutely nothing. So the focus here should be identifying and managing problems that you can fix, and that's why B is the right answer. The European resuscitation guidelines really nicely say this, is get your focus in traumatic arrest away from all these other maneuvers, refocus, I'm trying to fix something. And if I can't fix something, then there's nothing I can do to help the patient. Next slide. A child presents after a major blunt injury, has received 20 minutes of CPR and arrives with no signs of life. Continuing CPR in this patient is justified if the parents will be arriving soon, helps the medical team better manage a very stressful situation, helps build consensus that all interventions have been attempted, is paternalistic and deceptive, and supports the education and training of the team. So ethicists have looked at this. So this is basically a futile resuscitation. You've done everything, the patient is non-survivable. And so you make a decision, despite the fact that the patient has, there's nothing you can do to have this patient survive, you make a decision to continue anyway. And ethicists have, and I can provide the papers that give the argument for it, say that this is paternalistic and deceptive. And let me go through each of these things. Wait for the parents to come. So I saw this exactly done in our trauma bay one time. Horrible incident. It was a rollover ATV accident, and the kid came in with a devastating head injury, non-survivable head injury, had multiple minutes of CPR, 30, 45 minutes of CPR, came in, non-survivable injury. The team said, let's continue doing chest compressions on this kid until the parents arrived. The team made a decision that they felt it would be better for the parent to be there when the kid died. Well, this is just one incident, but let me tell you what happened. Is when the parents came in, the parents walked up to the bedside, and the team stopped chest compressions and declared the kid dead in front of the parents. The parent was upset in a very different way, which is, why are you not doing anything for my kid? So this team that had made a decision that this would be the best thing for the family, actually it sort of backfired in this circumstance. And so continuing CPR to have a parent stand there is probably not something that we should be doing. Helps the team better manage a stressful situation. So you just keep on doing CPR because we want the team to kind of get on board and make sure everybody's like, well, the reality is that there's no evidence that another 10 minutes or 15 minutes of CPR on a child that's going to die anyway helps the team in any way. That's something that people have made up. There's no evidence that that's true. Helps build a consensus that all interventions have been attempted. Well, either all interventions have been attempted or they haven't. And if all interventions have been attempted, continuing to just do chest compressions is not an intervention that matters. And so continuing the futile resuscitation doesn't really meet the spirit of C. And then the final thing is supports the education and training of the team. Well, I think this does the opposite. When you have a patient that has a non-survivable injury and you continue with the resuscitation, we're teaching the team the wrong thing. We're not teaching this team how to better resuscitate kids. We're teaching the team that futile resuscitation is part of our armamentarium of things to do. And in reality, it's not anything that's benefiting the kid in any way. And so the argument that this is an educational activity to do fetal resuscitation, I think has really very little support. And this is why I think that make a good decision, be definitive about it, follow the algorithm, but once you're at the end of the algorithm and there's nothing you can do, then present all the information that you have and stop. And I think that might be my last slide. And I think with that, I'm going to also stop. Thank you for your attention. I'll be happy to answer any questions if you have any.